Good morning. Forgive the little bit of haze you may find in my presentation. It's a residual of some Benadryl I took to rid myself of this northeastern virus. It's been a misery, especially in my family over the last week. And probably has something to do with the 30 inches of snow that we've had dumped on us that everyone enjoyed yesterday. Anyway, that's not what I'm here to talk to you about today. What I wanted to talk to you so far was about a short week of second opinions. I saw a number of people this week. I tend to see a number of second opinions simply because I'm situated in a tertiary care or advanced level care institution, and we are an academic center, which means we train the next generation of surgeons, and we tend to be a referral base for a very large catchment area. Anyway, there were some second opinions this week regarding the treatment of people with osteoarthritis of the knees. Some of these people were here to discuss whether or not I would do the knee replacement or whether or not they should go back to their previous surgeon and have them do the knee replacement. But I was surprised at very little of the discussions that the patient initiated began with the idea of, do I need a knee replacement? It seemed that they were more shopping around for where the knee replacement should be done. Now, let's say there were 10 of these patients. In the end, only 5 patients decided to have the surgery done. Why? Realistic expectations. We went through a relatively crude but useful shared decision-making process. We went through the fact that this truly is a quality of life decision, and it's not the doctor who makes the decision when you're thinking about a procedure that's here strictly to improve your quality of life and alleviate pain. So when the question was posed to the patient, do you feel that it's time to have a knee replacement? Do you feel that the pain that you're experiencing is significantly interfering in your quality of life, and you feel that you are willing to assume the risks of knee replacement in order to obtain that relief? When that question was posed to those 10 theoretical patients, and they weren't theoretical, they were real, the number is theoretical, half of them said no. Half of them said, I'm fine, I'll take my Tylenol or I'll use my cane, and I'll come back when my symptoms are very severe. That's the power of shared decision making. And it has very broad implications for healthcare as a whole. A lot of these patients were told they'll be up and around in a week, or that there really aren't any significant complications associated with the knee replacement. And, I'm not going to critique other physicians' work. However, it's all in the presentation. Once, it really is incumbent upon us as physicians to let people know exactly what it is they're in for as best as we can. We need to describe the reasonably foreseeable risks. If there's a risk that occurs of 1 in 1 million, or a risk that we cannot yet even conceive of, we're not held responsible for that. But things like infection and blood clots, and the fact that it can take 6 weeks to drive in some situations, or that 5% get stiff or 1% become infected, those are very important things to discuss with patients. Patients this week, predominantly adults with ACL deficient knees. That means
that the ACL of the anterior cruciate ligament was torn. They were coming again to see whether I would do the surgery or to see whether or not they should go back and have the surgery with their previous surgeon. The same questions were posed to them. Do you feel that the surgery is necessary? And
sometimes that's met with a blank face. And some people out there have certainly shouted out at me and said, it's your decision, you're the doctor. No, that's not necessarily true. I'm here to provide you with the facts. If your knee is buckling, unstable, or you're suffering from instability and the knee is giving way, you can't go up and down stairs, you can't turn, pivot, or twist, and braces and therapy and everything else have not improved your symptoms, then you can consider yourself a good candidate for an ACL reconstruction. If you will work on roofs, a tree climber, if you are a mountain climber, a rock climber, in those situations, I would suggest an immediate reconstruction simply because the first time your knee buckles, it may in fact cause significant injury, harm, or even death. However, for the vast majority of you, you have an ACL tear, yet you do not have any issues with your quality of life. You do not have any buckling, instability, or giving way. The knee may feel a little unusual, but yet it doesn't give out. Do you need an ACL reconstruction? I don't think so, but really, that is up to you. The indication for an ACL reconstruction is simply not its absence. It is the fact that it is causing an issue with your quality of life, with your ability to participate in activities that you would otherwise enjoy. There were other second opinions that I did this week for other lesser procedures, such as meniscal tears, etc. But it was the same story. These patients were being indicated for surgery by the presence of a finding on an X-ray or the presence of a finding on an MRI, not necessarily a custom-designed treatment plan based on how that injury was behaving in them. I put a blog post up on this a while ago. I called it the personality of an injury. It's simply because the same injury will not show itself or behave in the same way in many individuals. Some will be symptomatic, some will not be symptomatic, some will have problems, some will not. I've also talked about shared decision making before. This is a process where we go through your quality of life. There are a number of scores that we can utilize. We go through a list of the reasonably foreseeable risks, your expected goals, your outcomes, and the time that you can expect in rehabilitation before you will be quote unquote normal, if it in fact ever occurs. And once we go through all these processes, then people start to understand why I am not as aggressive, maybe I'll say, as others in recommending surgery, only because it doesn't seem to suit your injury properly. So, take-home message, pay attention to the shared decision-making principles. It's going to be a very prominent area in medicine soon. Seek out a second opinion. They are worthwhile. If necessary, seek out a third opinion. They are very worthwhile. And just because something shows up on an X-ray or an MRI doesn't mean it always needs to be treated surgically. You do have options. Find someone who's willing to explain those options to you and respond accordingly. Hope you have a wonderful day. Bye.